so excited for Core Group's first pitch challenge. This is the first time Core Group is hosting it, and we're excited to be able to support these entrepreneurial teams in trying to solve some of their community's toughest community health challenges. We had over 20 applications for this process, and with a consortium of judges, we were able to narrow that down to the top 5 teams you see and will be presenting today. We have 2 teams from Kenya, 1 team from Uganda, 1 team from Rwanda, and a global team representing multiple organizations and communities. Could you please give a huge welcoming applause to everyone on this stage. They put a lot of work into this process. And in our selection process, we considered level of impact, we considered innovation with the ability to scale, and we also considered the teams having some passionate, diverse leaders who were able to identify a problem in their community and come up with a compelling solution. We also wanted to empower the next generation of leaders while also looking at evidence-based programs, products, and campaigns. So I'm excited to introduce each of the teams. If we can have a microphone on stage. Can I get a microphone?
Yeah.
I'll have each of the team members introduce themselves. We'll start over here. Who wants to go first?
Yeah. Hello everyone. My name is Kostari Tanal. I come from Uganda. I work with Health Access Connect.
Hi, my name is Grace Muli from Kenya. I work with Water Youth Development Projects.
Good morning. I'm Faith Redding. Professionally, I'm a nurse and also work with Water Youth Development Project.
Good morning, everyone. My name is Peter. I'm the team leader for Water Youth Development Project, and glad to be here.
Hi, my name is Joshua Makasi from Water Youth member.
Good morning, everyone. I'm Victor Paspika. I'm watch from Rwanda. I'm part of David team for Rwanda. Thank you.
Good morning. I'm called Mulinzi Alexander Edgar. I'm a member of David team from Rwanda. I'm happy to be here.
Hi, everyone. My name is Dolman Fatinato. I'm a reproductive health youth advocate with the Girl Power team. Thank you.
Hi everyone, I'm Emmanuel Ekshon, Team Girl Power, Youth Advocate SRH.
Hello, I'm Niloya Esther and I'm part of the Girl Power team. Thank you.
Good morning everyone. I'm Georgina Obonyo. I'm a very passionate advocate on sexual reproductive health. And as a girl, I believe that every girl, no matter what, should have power, voice, and choice.
I'm Violet Birunji, and I'm part of the parent team. It's a global team, and I'm here working with Food for the Hungry, Uganda. So I can introduce our team. With me, I have Alison Schaefer from WHO's Department of Mental Health and Substance Abuse. Then we have Phil Moses, Erin Payfer, and Mary DeCosta from Food for the Hungry, Global Office. And then we have Bondala Ngwandu and Janine Sule with Project Concern. We have Sarah Shannon with Hesperian Health Guides, Fiona Coyette, Sarah Bowler, and Tom Davis from World Vision. And finally, we have Alison Flynn with World Relief. Thank you.
Thank you everyone. And as excited as I am for all of the teams on stage, we also have an amazing panelist of judges sitting right in front of us. We have representation from the private sector with Accenture and Africa Health Business. We've got representation from civil society organizations with UNICEF and Last Mile Health, and of course we have representation from the Ministry of Health. So I would like each of the judges to now introduce themselves. If you just want to stand up, say your name, what organization you are from, and your role or your organization's role in supporting and fostering innovation in global health.
Good morning, everybody.
My name is Marisa Lasha. I'm a co-founder and operations director at Africa Health Business. We're a private health advising consulting firm and also focusing on investments in the private health space. We have a better reach. And what we do in the innovation space is currently we are implementing a project with Virgin Energies Canada, where we are transforming or transitioning to scale 18 innovators. But apart from that, we work with a lot of partners, also SMEs and small scale startups, to help them get the visibility, networks, linkages, and also knowledge to grow the business. So apart from the DCC project, we also do that in other networks that we do. So overall, we are our mission is to strengthen the private health sector.
Great, thank you, Martha.
Good morning, everyone. Josh Krause with Accenture. I'm a manager in our health strategy practice. What I focus in on is growth and innovation. I guess that's why I'm here. Innovation comes in a lot of forms, so not just technology, but new business models, new partnerships, new ways to deliver care, given all the challenges in terms of financial and operational. So that's a lot of my focus is there, and also scaling new businesses, prototyping and incubating new businesses, and working across the region and globally. I'm happy to be here.
Thanks, Josh.
Morning, everyone. My name is John Oyungu from Ministry of Health, Kenya. Deputy Head, Division of Community Health Services. Currently, we are busy with the scale of BC and using community health strategy as the sure way to deliver BC in the country. So I'm happy to be here to educate over the big challenge. Thank you very much.
Thanks, John.
Good morning, everybody. My name is Lucy Jeremy. I work for UNICEF, Kenya Country Office. I'm happy to be here. Sorry, I'm trying to face everyone. I'm happy to be here. Innovation, what does that mean to UNICEF? I think for us, innovation is just responding to the local needs of the communities. And it came up in the morning about illiteracy and community health volunteers. And that's a big chunk of what we are doing, because we believe even in places where literacy is about 85%, like we have in Turkana and Masi, in Wajir, that those people still deserve to have community health volunteers. So we come up with ways in way to make their job aids pictorial, to help them provide ICCM. So in the case of defining diarrhea, 3 episodes of stool over 24 hours, we show the sun and we show the moon. If it is counting breaks, we have something like this, which you count, you have a timer. There's community health volunteer sets it to a minute, and then if you get to a red, when you're still counting the minute, you know it's fast breathing, you know you need to refer. So for us, innovation is just responding to the local needs of the people. Thank you.
Great. My name is Magnus Conte. I am the Executive Director of the Community Health Academy with Last Mile Health. I'm also on the Board of Directors for the core group. Very pleased to be here today, in fact over the last couple of days. The mission of Last Mile Health is in the name itself. We are focused on ensuring that no one is left behind and that we can take healthcare provision to the last mile. Those most remote and underserved communities that we find all over the globe, sometimes even within cities like Nairobi, you have urban slums that also constitute part of the last mile because healthcare is not delivered to them. But the Community Health Academy was set up to leverage the power of digital technology to improve the quality of training of the health workforce and accelerate the access of that training to reach the last mile. Most of our community health workers these days carry mobile phones. So why can't we take advantage of the mobile phones that they have in their hands and use a blended learning approach to deliver some of the content on the mobile phones in an accelerated way, in an enhanced way, but also still recognizing the need for face-to-face training through clinical skills lab, coaching, mentoring, and practicum. So that's what we are focused on, and also training health systems leaders, that is those leaders who lead implementation programs at the district level, but also at the national level that are responsible for policy and practice. Delivering online training programs to them so that also we can improve the quality of their skills and knowledge to design national scale community advocacy programs. Our first online training program was launched on the edX platform in May of this year. Already we have 10,000 learners from over 175 countries registered on that platform. That's the power of technology. Having said all of that, I just want to repeat a quote that was, a statement that was made this morning. Innovation. Innovation is not just about technology. I'm glad that was said. I'm happy to contribute to wrestling back the word innovation from technologies, because innovation is an English word. It's not a technology word. So let's innovate and do social innovation. Thank you.
And while we narrowed it down to the top 5, the judges have the difficult job of choosing the winner and the runner-up from the 5 teams. So give them an encouraging round of applause. And now each team will have 10 minutes on stage in total. 5 minutes for presentations and 5 minutes from questions from our judges panel. Each team, so we'll have a winner who will receive $5,000 and will be paired with a core group member from our member base relevant to the project that they're working on for the next year to help with implementation. And the runner-up will receive $4,000 and will be paired with a core group member as well. And then the remaining 3 will receive a consolation prize for being here, for putting all the work in, for 1 3-year membership to core group, or 1 conference attendance in a future conference. So now I will ask all of the teams to please exit through this door, and we'll start the presentations. Thank you. Woo!
Good morning, everyone.
Good morning.
This is the team from Rwanda. We are self-care champion group aiming at promoting comprehensive sexual health education in Rwanda.
As you see on the first slide there's a problem of increasing rate of teenage pregnancy in Rwanda. The Rwanda Demographic Health Survey reported that teenage pregnancy increased from 6.1% in 2010 and to 7.3% in 2015. And from 2016 to 2019, 17,000 teenage girls were reported to be impregnated. And this means that around 25 teenage girls are impregnated each day in Rwanda. This is really sad. It's really bad. Personally, I didn't know the severity of this problem until my cousin got pregnant. It was really bad. She dropped out of school. Her child became malnourished. She was affected psychologically, like she started abusing the drugs and engaging in unprotected sex and so forth. The research that was done by IOFP Rwanda revealed that 2/3 of youth get SRH information from their colleagues, from their peers, who also lack trusted information. So they spread unreliable information, and there is increasing spread of myths and misconceptions about SRH. So we decided to start an initiative called Youth Sexual Education through comic books and video. Previously. Yeah. You see the numbers? The initiative is called Youth Sexual Education through comic books and videos. Like, we started by doing community outreaches, teaching youth, and also writing articles and sharing them on social media. But later on, we realized that youth are more interested in attractive, entertaining, and digital tools like comic books and videos. That's when we started saying that instead of doing in the community teaching and then we leave, we come back and writing articles only, let's use those 2 tools, comic books and videos, to address that issue. So, and it's really having impact because we have now a YouTube channel called the Bahoneza Health TV where we share topics about SRH, and viewers and subscribers are really increasing, and now we are in a story correction phase to make our initial comic book, even though financial means are limited.
Our target group are young people from 12 years to 19 years. They are the most affected group in issue regarding teenage pregnancy. We make comics, and the way we make comic, we use human-centered design, an approach that involves the community from identification of the challenge, from the content development until the solution, the implementation of the solution. Meaning, we collect stories from teenage mothers, we collect some needs that caused them to get pregnancy, then we go to analyze the stories, then after analyzing the stories with views from some health experts, then we also go back to test if our stories we made are really impactful. Then afterward, we'll make the comic that will be used for educational purposes. Another thing is that we will design the comic in a way that will be easy followed by even school-age children, meaning should alive in poverty, knowing what is really the issue, what is really happening. So it will be interactive, and it can be self-directed, meaning you can read it by yourself and get the content, or teacher facilitated. So another point is that during the videos, we also we found that using motion pictures it's more engaging than just providing like a reading books. So what we need is that we want to engage them through videos, and at that point we also include people with disabilities, meaning those who can't listen until they will see, those who can't see until they will understand. So we'll make it more inclusive. Another thing about our team is that we are multidisciplinary, so we have various skills. Among our team, we have two medical doctor candidates. We have one global health analyst. We have community. We have a business planner. We also have IT engineer. So we don't need further resources for hiring people from abroad to come and implement. What we need is just to buy some materials and just use them for the implementation of our project. And that will help us in the sustainability of the project. And again, as social enterprise, we also measure the social impact based on partners who will need to come and use our comics, and also we will have also to track the success through the views of the video that we share and even the response from the community.
As our project is more inclusive for people with disabilities and with poor literacy, and we envision the world where young people will make right informed choices about their health. So as you see us, invest in us, support us to make great impact to the young people. Thank you.
We'll now take some questions from the judges panel.
Easy go.
Hurry up.
Thank you, Debbie team, for your very clear presentation. And we like the idea that you are trying to address the issue of increasing teenage pregnancy in Rwanda. My question is around social impact measurement. I would have wished to see how your intervention is impacting on the current problem of increasing teenage pregnancy by seeing another chart with low numbers of teenage pregnancy. Because you showed how it goes before your intervention, but you're showing us what has happened as a result of your intervention. Thank you.
Thank you very much, Nelda. My question is very simple actually, because we are talking about 12 years to 19 years, still children in the actual definition. So I was wondering about the involvement that you have with the parents and also the religious leaders.
Okay, thank you. On the first question of measuring social impact, like it's been around one year we started. So like we've been collecting feedback by using online forms, and also we visited to schools where we collected knowledge before teaching them and after. and found that knowledge was increasing to 17.2%. And now we've been challenged because we have few financial means. So like, if you believe in us or support us, we really have a big impact and we see the change to this problem.
For the second question about the involvement of parents, in Rwanda there is cultural barrier that parents are not able to communicate with their kids about the issue regarding SRH. But what the comics will do, in case a kid will be leading our comics, we get arranged and the comics will be like a boost of discussion between parents and the children. And also those videos, they will be spread, meaning when they will be watching video, they will get challenged. Then if a parent hear a child asking a sensitive question, he will be interested in delivering the clear information to help the kid.
In addition, our videos will cover different topics about SRH, but also they'll be made in the form of storytelling. We bring testimonies. So like those faith-based leaders, we bring them testimonies of young people who have been affected by this problem, and then encourage them like to also use their power to educate young people. And that kind of storytelling, we'll be planning outreaches, like planning outreach targeting parents. At that time, we'll be using videos that encourage parents to discuss with their kids. And if we target faith-based organizations, we use another kind of videos, because we make different kinds of videos depending on our target people.
Thank you. I love the human-centered design approach, very useful for this sector. Who is currently funding you, or how are you funded currently? And going forward, should you be successful here, how do you intend to make your funding sustainable?
We have 2 people who are working and 2 finalists and 3 finalist students. So like we save the money from our living allowance from the university, and we are 5 in the group, other who are working supported us. Like we collected around 2 million Rwandan francs from our savings. That's how we started the project. Didn't get any funding. That's why we've been stuck in the middle of the project. But now, like we are planning to grow, and the government, the Ministry of Health and IYFP promised to sponsor us. We are in the final also stages of being sponsored, but we have not yet got sponsorship. So if this one is added, it will be another value.
Another thing that we want to add more is just including at the level of the material that you can be using. Because in our team we are having skills, and you have a disciplinary team that can contribute. But if you are having like materials, we'll be able to keep our work up. Thank you.
Thank you.
Thank you.
So we all at some point might have bought and won bits. In fact, I'm sure that at some point, all of us might be running to the side market after this conference. True or false? But did you know that behind these bids, there is a cloud of pain, a cloud of sorrow, and a cloud of death for some girls in the community? In specific counties in Kenya, there is a practice called girl child bidding. As I share this story, I shake in pain and fear for girls, because I realize that some of us are privileged, but we are taking it for granted. Nashangai is an 11-year-old beautiful girl, happy, and she attends school. One night, Olesapit from her extended family visits the house. He pulls her mother aside and brother, and in a corner, they have a conversation. The next day, Olisapit comes and offers Nashangai a necklace woven with bright, beautiful beads. This is the beginning of a journey for Nashangai. Nashangai has been bidden, and this means that she is in a temporary sexual relationship with Ole Sapit. The mother builds a hut for them, just adjacent to their home, where Ole Sapit will now have access to Nashangai and have sex whenever he feels like. Ole Sapit rips through the petals of Nashangai, and he never uses a condom. Our poor little girl cries every day, but no one understands her. She is not allowed to get pregnant because Ole Sapit is a relative. And this will bring shame to the family. And eventually, they can't get married. But she eventually gets pregnant. She is told she cannot keep the pregnancy. All the women from her community gather around her. In a bid to abort the pregnancy, they hit her tummy several times. Nashangai cries in pain. And if that abortion will fail, then this child will be killed immediately it is born. Nashangai is now 12 years. She has undergone 2 abortions, has been affected by unsafe abortion, and will not be able to bear a child in the future. But she also finds out that she contracted HIV. She is now considered an outcast. The community ridicules her. She cannot talk to other girls and women. And she will never get married because she does not have a womb, as they say. This is just one story among hundreds of stories for Samburu girls between the age of 9 to 15 years. What are we going to do?
So what we are going to do, we are going to establish a girls' parliament that is going to spark conversation around media. But 2, we also seek to establish a technical working group in Samburu County, where they are going to start mapping a process of developing a policy to guide the investment towards the anti-vaping. How are we going to do this? Our approach is going to be a community-based approach where we are using the Morans who do the bidding as the champions by them sitting in the parliament. Number 2, on the other hand, we have the county forming a technical working group that is going to start mapping on how to develop a policy document that will guide investment towards anti-vaping. And so we invite you to assist our government in achieving its commitment of ending female genital mutilation and keeping girls in school. And by doing this, you have assisted these girls with one opportunity of doing what they want to in future and becoming what they want. And so we say...
We're actually out of time, so if you want to wrap up the last sentence.
No human is limited, and so are the girls.
And now we'll take questions from the judges.
And thank you for the very touching story and a real story. My question is, this is a plan for what you would like to do with the funding mentioned. What are you already doing in that field as we speak?
So previously, when we have engaged with this community, we have been having conversations, just trying to find out what is really happening. And what we have realized is that there's not a lot of research that has happened in terms of generating data to inform even a policy conversation. So what we have been able to do is to identify that this is a problem because communities and partners have been into the community and identified the problem, but no one is really speaking about it. So we have begun conversations, just speaking with the girls and understanding what they're going through.
2 questions. One is, what will you do with the funding directly once you have it? And then how are you going to measure progress?
All right, thank you very much for your question. Number 1, we're going to use the seed fund in supporting the county government of Samburu been establishing a technical working group to start working or developing a policy document that will guide investment towards the activity. Then we'll also use the fund to create a parliament in one of the sub-counties where the practice is so much intensified, so that we can start having the conversation. We don't want to impose to the community that bidding is bad. We want them themselves to discover that bidding is very bad and hefty for the girls. Thank you.
I also agree with wanting to collaborate with county governments and the public sector. I know AMREF is already doing a lot also in the field of FGM, and I also plan to partner with those type of NGOs for CSO.
Yeah, we are also looking at AMREF as one of the partners because they have done a lot of work around FGM, and actually bidding is a precursor to FGM. So what happens is that the girls are bidded, and then they are prepared for FGM and prepared for marriage. So we're looking at partnering with such organization, and the technical working group that we aim to establish will be a multi-sectoral, bringing together the girls, the morals who bid, the girls themselves, the community, private sector. First Lady is also part of our group, by the way. She was not able to make it, but she's part of the group. So we are looking at working with such people who have convening power to be able to achieve. Just identify that this is a problem.
Thank you, Team Samburu, for a very elaborate plan to bring to the end the FGM menace in Samburu County. If only you could quantify the problem so that when you have improved, you can show the improvement, and that could assist. But I think it's a worthy project. Thank you.
You know, when you say child bidding, my mind went to child labor, children making necklaces, so I was not prepared for the story that you told now. But just, you mentioned the First Lady is part of your team. Just tell us a little bit more about the team that is behind this whole project.
An explanation about the team? Yes, so we are a team of passionate advocates who have been working with different county governments in terms of meaningful youth engagement and bringing community and youth voices to this space. So what we are able to do is to identify the problem being on the table. Now the First Lady is part of this group because she is very passionate about girls going back to school. And if this is a problem, if we are able to work around it, then we'll ensure that girls are able to go back to school.
Thank you. My question is actually around further clarification on the intervention. You mentioned setting up the technical working group. I caught that bit, but I missed what else you were doing as an organization.
So we're going to support the county government of Samburu to form a technical working group with the seed fund that we're going to get, so that they can start driving conversation around that and seeing how they're going to establish a policy guide that will be focusing on anti-bidding, so that even the community understands that it's wrong to do this, bidding is wrong, while at the other side, we're starting a conversation at the community level where the morons themselves being the champions, so it comes and converts. Yes.
Thank you. And also to just challenge the Ministry of Health in Kenya, because girl child bidding has not been identified as a human right violation or a harmful practice, but it is. Thank you.
Thank you, everyone. Good morning to you all. For Health Access Connect, and hopefully, because I'm presenting alone, hopefully I'll be deserving of your listening. To start with, the first 2 days I have been here, and for the sessions today, I'm more than convinced that as global health practitioners, all gathered here today, we are all in agreement that distance is a great challenge to health. And if we are not catering for distance, then we are very far from achieving health for all. The situation in my local country, Uganda, is that health services are free of charge, but by very far, they are facility-based. What does this mean? This means that the further an individual is from a health facility, the less likely it is that this individual will access health care even if they are free of charge. Unfortunately, this affects the mothers and the children more than the men in our communities. At Health Access Connect, we link remote areas that are very far from health facilities with these free health resources. This is where we need to go. We need to have our governments embrace systems that are not facility-based alone. We need to have our governments embrace community health care. And as our governments battle with the challenges of budgeting and having this health, community health into their budgets, we as implementing partners, we need to develop models that are actually going to be replicable by the government when it's time for them to open this up. We need to develop models that hold the public health care banner high. Models that are going to commit to community participation. Models that are coming at a cost that the community and the governments, when it's time for them to take them on, shall be able to maintain the cost at every level of development. At Health Access Connect, our solution to the global challenge of distance is the MedCycles program. The MedCycles program ensures integrated outreaches and fosters community participation. It has 3 parts. 1, we have reliable transportation. And when we look at reliable transportation, we are looking at transportation that is cost-effective and transportation that can actually reach the very far areas of these remote areas. So we use boda-bodas. I don't know how it's called here, but we call them boda-bodas, the motorcycle taxis. And in the islands, we use the boat taxis to reach out to these communities. The second part of the MedCycles program is the monthly outreaches. And these outreaches are integrated outreaches that are carried out by public health facility workers. 3 to 4 health workers move out to a community, carry out an integrated outreach, and provide services to the people. Then the third and most important part of the MedCycles is the community oversight that is headed by the PhDs called them GHPC. And with this, the community health volunteers ensure that the community takes the uppermost hand in this. The community health volunteers calls in to confirm an outreach shall happen. Then they do the mobilization, and then they collect a small contribution from everyone who attends the clinics. This, when put together at the end of the day, caters for the transportation and the SDAs, we call them safari day allowances for the health workers. This makes health access not very needed in these situations. The long-term impact of what we do is that these communities can sustainably receive health services without Health Access Connect, and we don't have funding. If the judges say we receive the funding today, I hope they will. We hope to use the funding to integrate more of health promotion in our activities. Thank you very much.
And now from our judges.
Thank you for the presentation and supporting local communities to take responsibility for their own healthcare provision as well. I'd just like to get a bit of clarification on the leadership of your team. Or what structure do you have in terms of leading your work?
Yeah, thank you, Team Uganda. Maybe we could talk a little bit about your sustainability plan, how you plan to sustain your program to improve the viable use of the borders to enhance access to healthcare. How do you plan to sustain that beyond the seed money?
About our team, Health Access Connect is a team that is basically made up of 3 field officers, 1 coordinator, and We also have an executive director, an M&E officer, and a finance officer. We basically work in 5 regions. We're a small team, but we do the work because we're greatly partnering with the public health facilities. Sustainability, because we're using the border. The border is the most affordable type of transport in Uganda. And that is why we choose it. Because we know that even after Health Access Connects funding, it is the kind of fund that the community can most ably afford. And we have had situations where the sub-county leadership has taken up the transportation role themselves, so the community will only have to take care of the SDAs for the health workers. Yes.
Okay, a little bit of clarification on the business model. So wondering what the services that are being provided when they go out to the community, diagnostic or is it consultative? And wondering how you partner with the health facilities to get them to give up labor for the day given their shortages as well. How are you navigating that conversation?
I'm sure you mentioned, but maybe just repeat for us the innovative parts of your model. That's number one. Number two, on the small contribution. Is that voluntary or is it everybody that comes again that has to give something? And how do you communicate that to people, given that other services are free, but now that you're coming to me, I have to give something small, and how that affects my out-of-pocket costs?
Thank you very much. About the services that are offered, it's a process to get one outreach to get started. We have a lot to sort out right from the district health team to the health facility. But we have a memorandum of understanding with the health facilities that all services that can be offered in the field are actually offered there. In the outreaches, we have health promotion sessions, we have family planning, we have antenatal care, we have postnatal care, there is immunization, there is ART therapy, there are lab tests, all that can be done in the field are done there. It's just taking the facility to the community. About the innovativeness, this model looks at linking the community to the health facility. Now, it's very true that all these health services are free of charge, but we need to talk to the health facilities because they're budgeting for these communities. These are their catchment areas, and they have road drives to the facilities for them. But distance is standing in the way for these people in the remote areas. And someone needs to talk to the health facility that, hey, you have budgeted for these people, and they need a service. So that is what we try to do. About the contribution, we make sure it is that everyone is supposed to provide a contribution to this transport. But it's much far less than what they would have used to reach the health facility. And the community has the uppermost hand to decide on some special cases like orphan and vulnerable people, like the disabilities, where we don't expect people, you don't expect this family to be bringing anything. We have a family of blind people. The community weighs them off at their own discretion because it's their power. And they choose to say, hey, you can take 2 bottles every evening. You can afford this contribution. And then they say, this is too old. She can't afford this contribution. It's to the community.
Thank you so much. Okay, so maybe the last one. So how has access improved with all the efforts and all the innovations? How has it improved? How has it changed over time?
Health access over time. We started in Kalanga district. We're now operating, overseeing 75 outreaches in 5 districts of Uganda. And we are hoping to move to open up 60 outreaches in 2020. But obviously focusing on those areas that are very far from the health facilities. Thank you.
Thank you. Your health access.
Morning, everyone. I want to tell you about an exciting, thank you very much. I want to tell you about an exciting initiative that will leverage the core group's potential to dramatically improve children's physical, emotional, and intellectual development. Core group members have achieved a whole lot in terms of on the child survival front, yet there's much to be done to help children thrive so that we can transform health and human potential. First, it's time to devote more attention to the nurturing care of children. Brains are built, not just made, and early childhood experiences have a profound impact on learning, health, behavior, relationships, and earnings as adults. Creating nurturing environments influences key child health and well-being outcomes across all the developmental phases. And in response to this urgent need, the WHO, UNICEF, and World Bank, in collaboration with other partners, created the Nurturing Care Framework, which was launched at last year's World Health Assembly in Geneva. The framework promotes much of what we as core group partners already do, but encourages us to focus more on responsive care, early learning, and caregiver mental health. It's also time to devote a lot more attention to maternal depression and caregiver depression. It's a worldwide public health issue that can have a negative impact on a mother's life, work, family, and the health and development of her child. A recent meta-analysis found that we may be able to reduce stunting by 27% if we eliminated maternal depression. Food for the Hungry and World Vision just completed research in Uganda where we saw that women without depression had much better adoption of health, nutrition, and wash behaviors compared to women with depression. On average, 22 points better adoption. 1/3 of pregnant women and a new mother suffer mild to severe depression, and in Tanzania, the prevalence of antepartum depression is 40%, and in Uganda, it's 43%. Yet very few of these women receive evidence-based treatment. So here's the plan. Core group members will work with the WHO technical support to scale up nurturing care coupled with maternal depression interventions in some badly affected African countries to show how children thrive when they're raised in nurturing, safe, and loving home environments by parents with very good mental health. We call the initiative PARENT, which stands for Parenting with Resilience and Early Nurturing Care for Transformation. Violet?
Can we do this? Yes. Food for the Hungry, Project Concern International, World Vision, and other core partners have already been expanding their use of the care group approach to focus more on nurturing care, especially early child development and education and child protection. Published evidence proves that the care group approach improves health, nutrition, and wash outcomes, and that projects using this approach achieve on average double the behavior change of traditional community health work models and 53% better reduction in estimated child deaths. Some core group members are finding that the care groups are also bringing about improvements in early child development, child protection, and other elements of nurturing care as well. Core group members and the WHO have also had success with reducing depression in parents in Uganda. Both Food for the Hungry and World Vision have supported parents experiencing depression, helping to reduce depression by more than 93% in only 3 months in 2 separate trials using a low-cost, short-duration, evidence-based approach for psychosocial approaches. In Kenya, World Vision has partnered with the Ministry of Health to train 1,500 community health volunteers in a similar intervention, proven to lower depression, anxiety, and post-traumatic stress disorder through just 5 90-minute skill-based visits. Meanwhile, the WHO has evidence-based approaches to significantly reduce peri- and postpartum depression.
So quickly, what will we do? How are we going to do this? Well, together with other core group members, we'll use the seed money to create a nurturing care group project model and training manual for scaling up the nurturing care framework, especially within our strength area of increasing parent skills and adoption of important behaviors. This model will incorporate effective, easy-to-learn interventions to reduce depression in caregivers that have been shown to work in Kenya, Uganda, and other parts of the world. World Vision will invite core group members to improve its draft Nurturing Care Groups Training Guide, co-produced by our team member Hesperian Health Guides, that draws on FH's and PCI's work. PCI will draw on their effective use of education cascade groups in Tanzania, And we plan to leverage CRS's successful Drive and IMDC work as well. I'm on the Nurturing Care Framework Implementation Working Group in Geneva, and our team member Allison Schaefer is a technical officer at WHO. And we're going to work together to help accelerate mental health interventions. But to ensure caregivers' good mental health and children's well-being, the WHO needs incredible creativity and boots on the ground that core group members have. And together, the WHO and core group members will then test this model in more African countries and then scale it. Help us to get this parent initiative off the ground so that we can rally core group members behind a truly life-saving cause. Thank you very much.
Thank you.
I heard you have quite some partners already who have mentioned and maintained some big names. What if you would not give the money today? Would the project still happen and who would fund it? Or is this what's your plan B?
Okay, most of the partners that are on the team are actually planning to scale it up. For example, in Uganda, the government is planning to scale up care group approach starting January 2020, and Food for the Hungry is partnering with them to actually provide support, monitoring, and also direction in the implementation.
I'll add though that finding money to do a joint model like this is often a little bit hard to piece it together. So having the money helps to basically ensure that we come up with a deliverable, which even if we have a partner that says we decided this is not important this year, we would have to keep moving forward, and it'll kind of give us that discipline to do so.
Just basically to develop the manual and come up with a manual that the core group members will use.
Yeah, thank you. Wondering from a financial standpoint, so is this primarily donor-based? How do you see this evolving in the future from a financial standpoint?
Well, what I see is that we're really working towards giving governments a tool that they can use to be able to do the nurturing care framework, to scale that up at low cost with the care group approach using a lot of community health volunteers, but working with paid community health workers usually. So this will give them a tool to do all these different behaviors that often it's just too time consuming for one promoter, one community health worker to do. So this will give them a tool that will help them to do that. So we figure it's basically mainly that governments would scale this up and other INGOs with using project money. And the same way that they scaled up the care group approach to over 30 countries.
Maybe to give you a practical bit of it, both Kenya, Tanzania, and Uganda, the care group approach is working at the moment, but we're just improving and embedding the mental health treatment as well. So what has happened is that because we're using the government structures to implement these care groups, the sustainability is available because the government structures are actually supporting and monitoring the care groups, but also we have found that we need to integrate it with livelihoods such that these groups have a purpose to meet, not only to socialize and get over with depression, but as well as to have an income, a livelihood that actually promotes these groups to meet often and make sure that their lives are enhanced. Yes, the scale? Okay, yes, as I said, because this model has been proven to be working, and actually the sustainability has been on for the last 4 years. All the care groups that have been formed are still there. Why? Because of the integration with livelihood, but at the same time they are owning it as the government for its people, and it has worked to reduce the depression.
So since they're already scaling up care groups, broadening the model shouldn't be as difficult. Yeah, thanks.
Yes, thank you. As a mental health nurse, I recognize the importance of what you're trying to do. But one of the challenges is the stigmatization of mental health in communities. If we put the government aside for a minute, you might get buy-in from the government, which usually is very difficult, but increasingly the momentum towards supporting mental health programs is increasing. But it is still very challenging at the community level for somebody to self-identify or for them to be identified by professionals as having depression, which is common, but still to be professionally labeled. I just wanted to get a sense of what community engagement strategies would you put in place to address stigmatization?
Well, I can tell you a bit about our experience in Kitgum with that. We actually, I feel like, really confronted that. But part of it is by rolling this into care groups, and again, nurturing care groups, it's easier because it's just people who are participating in a community group that revolves around nurturing care, and it happens to treat also for depression. and help prevent depression as well.
All right, so our experience was that we first had to sensitize the government, workers and health workers, and the entire population, the community leaders, the religious leaders, people who are seen and recognized in community and have an influence on what is depression, the different types, so that they can accept it and understand what it is in detail. So what happened is that because of these leaders or people with influence that actually understood depression, it was easy for us to go to the communities and actually gather them and sensitize them. And what happened is that most of the ladies, we found that the percentage of depression was very high. It was 30% according to the tools, and the government actually had to support us in training all the health workers in over 70 districts now in Uganda how to access, identify, and screen for depression. And we realized that in those settlement areas that we are actually working with refugees, the percentage of depression was actually much higher. And so this created an awareness, something that has been shocked to find out that actually depression is such a very big cause from IPV mostly, and I think SGBV as the results. And so government took it up to actually help expand whatever approach that we had developed to actually reduce mental health depression.
WHO has actually recommended considering thinking healthy and using that as a model, which can be used with all women. So it actually be an intervention that leads to less stigma because every single woman is getting this depression prevention model rolled into it as well.
Great, thank you. Let's give Harry a round of applause.
HIV is still a very stigmatizing disease. The system still wants people to be provider-initiated by going to the facility to get tested. Water Youth Development Projects is set to present a model that is community-initiated, where the community can be able to take charge of their health. In HIV, people are discriminated upon. We have men who have sex with men. They cannot be able to openly go to for testing at our facilities. We have teenagers who are pregnant who feel ashamed to go for HIV testing at the facility as the first to know their status. We have people are stigmatized, and yet science has given us a testing kit which is painless, which is fast, which is easy, and which is private. So what are we waiting for? Why do we still want many people to go to the hospital to be tested by another party? What youth projects want to present a model where the community themselves initiate their own testing, and when they are positive, they go to the hospital for confirmation and care services. How will Water Youth Development Project do this? We got this one from our Makwemi Level 4 facility. They are given free, but fewer people are going there to collect it. Recent survey found that it takes 8 hours to get services in public hospitals. And the youth are impatient. They don't want to wait for 8 hours. They don't want to be asked those many embarrassing questions so that they can be able to get to be tested at the facility. We have a number of youth that are getting pregnant. Teenage pregnancy is a problem here in Kenya. Defilement is also increasing in Kenya. And then we have very mobile youth that are doing whatever they are doing taxi using motorbike. They don't have time to sit for 8 hours to get tested. How is Water Youth going to do this? Already we have a youth-friendly facility where youth normally come to pick their condoms, where they also come to pick to talk to their peers at the facility. So we want to add another element of it where they can be able to come and pick a self-testing kit under the guidance of office counselor. But the key point here is that after counseling and testing, they have to whether they will be tested at the facility with the help of the counselor, or they will want to take it away at home to go and test themselves. They must go to the facility, to the hospital again, for confirmation and a test and be enrolled into care. What is preparation? So let us make oral quick available to the people who need it most. And the people who need it most are the underage youth who are sexually active and expectant mothers who need to know their status before they give birth. Thank you very much.
Well done. I think it's a good initiative. I have two questions for you. The first one is, how do you keep track of the? Do you just give are they just given away and then people come back at will, or how do you keep track of who has taken so you can know whether there's follow-up that's needed? The second one, we always talk about HIV testing and counseling. We always talk about monitoring testing and counseling. How are we going to deal with the counseling component of when I test at home and I come out, whatever the results is positive or negative, but mostly positive, and I'm at home when I'm supposed to be cancelled almost immediately? How do we deal with that part of taking this test at home?
Yeah, thank you very much for the question. Young girls always go to buy e-pills after sex. How do they deal with that at home when they get pregnant? So we want to have a culture where you own your own health. And so you are, when you're coming to pick this item already, we'll tell you that you take this, whatever results you expect, if you're positive, you have to go for counseling and care. If you test negative, then you sustain a good lifestyle. Second question, please. Yeah, we have a register. When you come to pick this item, whether you are a youth or any other public, we only need your telephone number. We don't need your name. Using your telephone number, we can track whether you went for referral or whether you need some assistance. Thank you.
Clarification on what you're going to use the funding for. So are you looking to increase counseling or workers at the actual facility? Are you looking for increasing supply? I guess where is the money going to come? Where is the money going to go?
We are looking for a partnership. This cost 500 Kenyan shillings. That's about $5 US. We got this from our public health hospital. They're given free. So we have a partnership where we normally collect condoms, and if we don't have enough supply, we'll be able to partner with people and we get more of this material.
Okay, so you're using the money to procure more?
Yes, and also to engage peer groups to be helping in that aspect.
Yeah, thank you. About the cost-effectiveness of this approach to HIV testing, we know there's a cost to the kids, and there's a push from the HIV space to do targeted testing in a bid to avoid wastage of test kits. So how are you balancing this with the push for targeted testing as opposed to everybody using test kits that cost money to test even when maybe the test is not indicated? That is one. Two, there is the issue of a court order that was made, the fact that only lab techs should undertake lab tests generally in the country in Kenya. So how are you dealing with this in view of the fact that it's only lab techs who are supposed to undertake lab tests and not just any other person?
Thank you. I'll start with the last question about the lab tests. Yeah, I'm aware of the court order in Kenya. And yesterday, during one of our innovative presentation, we heard that if you can train a dog to go to the post office, how difficult would it be difficult to train a human being at the community level to provide the same services? without dealing directly with the professional at the laboratory. So I'm borrowing from that honestly, if people are given their own hammer and they are able to do similar things that are not highly professional. So that kind of order, I'm sure, when we were talking about hearing our voice, hearing the community voice, that kind of order might be relevant.
Thank you. A couple of questions. The first one is I just want to know whether you've thought about how you could integrate the provision of these kits with other services that you're providing to the youth, whether they are sexual and reproductive health related services or other services that you know the youths would be interested in, and during that visit, you provide them with the testing. The second question is around the leadership of your organization, your work. If you could just give us a bit of clarification on that. And who are the members of your team?
The first question is leadership, and the last question leadership, and the first one. The other one is integrating. Yeah. Yes. As I mentioned earlier, we have a library where the youth come to collect books, and we have a small room where they also come to pick columns, and that is run by youth only. At the front of the office is a sports shop where they buy and get sports equipment. So we have that camouflage, and therefore we are able to integrate all the services as we expand to cover all those requirements that the youth need. The leadership, we have a board member, and we have it's a youth-run organization, so these are members of the community of the youth. We have others at home that are linked to the whole process. To answer the other question of the cost, we just heard about the cost of the gene expert cartridges. They are very expensive. But at the same time, we are insisting that every person who is coughing should be tested using the gene expert as the first point of test. What does that mean? The human life is more important, has no value. It's just about a partnership, and then we can able to do it.
Great, thank you to Youth Development. Everyone, give them a round of applause. I'm going to announce the consolation prize winners, and then John's going to come up and give the runner-up and winner awards. Whichever you think. All right, so for our 3 consolation prize winners, we have, drumroll, Health Access Connect, Parent and World Youth Development Projects. We have one representative from the team. Thank you so much. Thank you so much. And now for, yes, come on.
So finally,